session of IMO PG training. And today's topic is on carcinoma lung. And our presenter for the day is Dr. Fatima. She is a third year resident from Aster MIMS, Calicut. And we have our two esteemed examiners, Dr. N.K. Warrior sir from MBR Calicut and Dr. Anup TM sir from RCC Trivandrum. So without further delay, I think we can start now. Dr. Fatima, over to you. We can start the case presentation.
Good evening, all. So my patient is a 42-year-old male who works in the Gulf and his hometown is in Vadakara. He presented with a complaint of non-productive cough for the past 3 weeks. He was in his usual state of health until 3 weeks back when he developed insidiously a cough, which was non-productive in nature. There was no significant aggravating or relieving factors. There was no diurnal variation in symptoms. There was no positional variation in symptoms, and it was not relieved by over-the-counter symptomatic measures. Due to non-relief of symptoms, his physician ordered a chest X-ray. He was then referred to the pulmonologist due to the presence of worrying symptoms on imaging. There was no history of fever. There was no history of blood in sputum. There was no history of breathlessness, no history of wheeze, no history of pedal edema or facial puffiness. There was no history of back pain or bone pain. There was no history of abdominal distension, headache, or seizures. He does not give any complaints of discoloration of sclera or urine. There was no history of change in the quality of voice, no history of fatigue, weight loss, loss of appetite. Past history, he is apparently healthy. No history of hospitalization. He is a recently detected diabetic and he has been started on oral hypoglycemic agents. No history of tuberculosis, hypertension, CAD, or cerebrovascular accident. The patient is a never smoker and he is a non-alcoholic. He consumes a mixed diet. He has a normal bowel and bladder habits. He has no significant family history. To summarize, this is a 42-year-old male, a never smoker with no significant medical history, presented with a persistent cough and was referred to a pulmonologist following a chest X-ray that revealed a suspicious mass. The presence of a pulmonary mass, which could represent an infectious or a malignant process, further investigation is required to determine the exact nature of the mass.
Okay. Anup, can I start?
Yeah, sir, please.
Yeah, Fatima, you have done a very nice presentation. Basically, the history you have covered almost all positive and negative things. Like you mentioned about the hemoptysis. By mentioning hemoptysis, what do you mean by? Will you be able to get some information on hemoptysis if the patient has got hemoptysis?
If it is a hemoptysis, it could mean that he has an infiltration or a cavitary lesion. It could mean a malignant process. It could be an infectious process such as tuberculosis.
Mainly interstitial lesions, which will give us a clue to guide the biopsy, or we can decide the way we can do the biopsy in addition to all the imaging biopsy. Also, you have mentioned about the hoarseness, the no change in voice. So does it mean patient doesn't, what do you think the patient doesn't have hoarseness means?
If there is a mediastinal node involvement that is compressing the recurrent laryngeal nerve, the patient may present the hoarseness of voice.
Again, indicating that the mediastinal is not involved, and maybe what we are dealing is an early case of lung cancer. If at all, we don't know about the pathology, but if at all it is early malignancy. But you mentioned about but headache probably a good indicator. But can you describe the type of the headache we get in the malignancy associated, especially in a case of lung? You expect 20 to 30% patients will be having upfront brain metastasis. So what type of what is the nature of the headache that will differentiate you from differentiate that headache from the other causes?
Unlike a migrainous headache, it is not hemicranial. It is usually occipital. It is usually a strenuous type of headache. If it is associated with a raised intracranial pressure, he might present with cranial neurological deficits, vomiting, etc.
Okay, yeah. So a sustained headache and associated with all the central type of headache. Okay. So, but one thing I was surprised to see that you have not mentioned anything about the family history. Do you think family history is important in lung cancer?
So, if it is, we do not know if it is a primary lung or a metastatic to the lung. So there are family disposition for CA rectum, etc. And then even in lung cancer, there is very few family disposition, etc. Especially in the 15q, 5q, 6p locus mutation.
Pardon?
In the lung cancer, there is a very few familial disposition, especially.
Okay. Yeah. So you think it's basically not much role, but suppose this patient's sister also had lung in the past, then what do you think?
If it is a primary lung cancer, then I will definitely look for any germline mutations, or if there is any clustering of cases because of a common exposure.
What type of germline mutation you will be looking for? So you know that T790 mutations, if detected upfront, it will be pointed towards
Yes.
germline. So a family history is coming up in a probably in a or you're playing an important role. So family history, don't miss the family history, and also Lee-Fromani syndrome, TP53 mutations and all. You can ask about the family history where people sometimes having osteogenesis sarcoma and lung cancer and also the HER2 mutation and especially the ERBB mutation has got again a familial predisposition. So differentiating somatic versus germline mutation is also becoming important in case of primary lung cancer. Okay.
Yes.
So Anup, anything to add from the history?
No, sir. Fatima, from
Yes.
your summary, so what is your first differential diagnosis? First one. So
Sir,
with a 42-year-old male with a short history of cough, and you get something in the lung as a mass. So what is your diagnosis? First diagnosis.
So because he's a never smoker, he's a young male. First of all, I would like to think of any infectious benign processes, a chronic bronchitis with an underlying hamartoma or lipoma inside the lung. I would want to not jump into a malignant process right from the first.
Okay.
But
anything which suggestive of a malignant process here from your history?
He does not have any fevers, and the nature of the cough is also, it is not associated with sputum. There is no diurnal variations, and not much relief with over-the-counter medications.
Okay. So how will you take up this case?
So first of all, I will look at the chest X-ray. Chest X-ray was done from outside, and there was a sizable lesion in the chest X-ray.
So before going to the chest X-ray, Fatima, you want to tell something
about examination,
the physical examination and.
Yes, sir. So I will do a complete clinical examination. On general examination, he had an ECOG PS of 1, was moderately built and well nourished, no pallor, icterus, cyanosis, clubbing, no lymphadenopathy, no pedal edema, no spine tenderness. The vitals were stable. On respiratory system examination, his respiratory rate was 22 per minute. Abdominal thoracic.
Okay, so you can skip this.
Palpation confirmed the inspection findings. This is the percussion and auscultation findings, and also the other system examination was also grossly within normal limits.
You can summarize, then you can summarize properly.
A 42-year-old male who's a never smoker comes with a 3-week persistent non-productive cough with a chest X-ray findings of a sizable lesion. So I want to further investigate him to characterize the lesion.
So did you specifically look for any nodes in the neck? You have just mentioned that no lymphadenopathy, but did you specifically look for any nodes in the?
Yes, sir. The supraclavicular nodes were completely.
So what is the importance of supraclavicular when you are suspecting a primary lung? what stage it would qualify?
It will become an N3 nodal stage disease. So it will become a stage 3 disease, an advanced stage disease.
That is, you are talking about the ipsilateral. What about the contralateral?
So supraclavicular node, even if it is ipsilateral or contralateral, it becomes N3 disease.
Good, very good. Yeah. Okay. Anup, something you wanted to ask?
Yes. So what are the other general examination findings, particularly you look into when you examine a patient with a carcinoma, suspected carcinoma lung? What all positive general examination findings?
Look at the PS of the patient, general fitness of the patient. Then for pallor, icterus for any liver involvement. Then cyanosis if there is any patient having lymphangitis, hypoxia, etc. Clubbing in a chronic COPD patient, sudden onset clubbing. It can be a paraneoplastic symptom or a heralding sign of a malignancy. Then of course lymphadenopathy. Then pedal edema if the patient has a right heart failure. Etc. Then facial puffiness if the patient has a SVCO obstruction. Then if the patient has a Pancoast tumor, I will look for signs of Horner syndrome. Then any weakness in the small muscles of the hand. Then any signs of pigmentation, knuckles. Then
something which you have not mentioned in your general examination, Fatima, about did you see any skin for any, did you look for any skin lesion specifically? Because the skin lesion he found, because it's common that to get skin lesions in a primary lung cancer. So never forget to see skin.
Yes.
Specifically look for any cutaneous deposits, and that will immediately qualify for stage 4 disease, right?
Yes, sir.
And what about eye examination?
Eye examination, first of all, we can look for pallor, we can look for icterus. Then if there is any partial ptosis, there is any meiosis, anophthalmos, etc., pointed towards Horner syndrome. Then of course, any cranial nerve involvement as part of a CNS mets, the patient can have a extraocular movement, asynchronicity between both eyes. Then the heliotrope rash of a dermatomyositis, which is a paraneoplastic syndrome.
Okay. So now you have a 42-year-old non-smoker presenting with respiratory symptoms and suspected mass in the chest. So how will you proceed then further?
First of all, look at the basic blood investigations, the basic biochemical profile, any pointers towards infectious such as high leukocyte counts, then any paraneoplastic hyponatremia, any paraneoplastic hypercalcemia. Once the blood investigations are okay, then I want to characterize the lung lesion. I will go for a contrast-enhanced CT, thorax, and upper.
Anything in the blood, which commonly we look, immediately the moment you get the blood report. What all things you have already mentioned, but anything in the liver function test, which will be an indicator of the stage.
So, any alkaline phosphatase increase.
Yeah, good. Yeah. So what all investigations you are talking about the CT, chest CT?
Yes, sir. So to characterize that lung lesion we saw on the chest X-ray, I would like to take a contrast-enhanced CT thorax with upper abdominal cuts. And it will help me to characterize the lesion. If there is a contrast enhancement, the margin of the lesion, the attenuation of the lesion, and to see the T staging, how it is encroaching the surrounding structures. I would also look at the mediastinal nodes, mediastinal structures, the bony involvement, the pleural involvement.
So may you tell me the T size, T staging of lung cancer? Just quick.
Yes, sir. T1 is less than or equal to 3 centimeter disease. T1 MI is with a microinvasion less than 5 millimeter. T1 A, B, C is less than 1, 1 to 2, 2 to 3. T2 is more than 3, less than or equal to 5 centimeter disease. Or the visceral pleura involvement, the invasion into an adjacent lobe, or a main Broca's involvement. Then T3 is more than 5, less than or equal to 7 centimeter.
Okay. So let me ask you one thing. The tumor of T size 2.5 centimeter with pleural involvement. So what T stage is this?
So if it is the visceral pleural involvement, it will become T2. If it is the parietal pleural involvement, it will become T3.
Okay. So then what about the skip lesions or not skip lesions, actually, the satellite nodules?
Yes, sir. If it is a separate tumor nodule within the same lobe, it becomes a T3 disease. If it is a separate tumor nodule in the another
Same
lobe
side?
in the ipsilateral side, T4.
Okay. Okay. Anup.
Yeah. Can you show the imaging of this patient?
Yeah.
So what is the image? Can you define the image here?
So this is the HRCT thorax.
You have the X-ray with you?
Unfortunately, no, so it was taken from outside, sir.
Okay. But it is important in examination.
Yes, sir.
Examiners will ask you to interpret the chest X-ray first before going to CT. Okay.
Always try to get the the chest X-ray and collect it and keep it ready. Okay, during your examination.
Yes, sir.
So describe this lesion.
This is a nearly rounded lesion with irregular borders and a solid lesion, nearly 2 to 3 centimeter in the left hemithorax, surrounded by normal parenchyma. I can see some pleural attachments. In this image, I can't see any mediastinal nodal involvement of. This is an HRCT thorax, though.
So mediastinum is not involved, right?
Sir, in this image.
Okay. So mediastinum. So what is the clinical stage with this? Suppose this is primary lung malignancy. What is the stage? Clinical stage.
Sir, this is a T3 N0 disease. So AJCC 9, it will be a stage 2B disease.
Stage 2B.
This is the
okay.
CT3 CN0.
Okay.
Will you go for
yeah, Anup, please.
Yeah. What is the indication for a PET CT here? Any indication? So
Yes, sir.
when you will go for a PET CT over contrast CT chest abdominal?
Yes. So the sensitivity and specificity to detect the mediastinal nodal involvement is higher in a PET CT as compared to a CCT thorax. With a single imaging modality, we can also comment on the distant metastasis, bony involvement.
So what percentage of lesions will be upstage?
So 20%.
20%, correct. Yeah. Good. So now so what all other investigations you will be doing for this patient?
So the imaging I will see is first to diagnose the disease, then for staging, and then for fitness for treatment. So to diagnose him, now I want a histopathological diagnosis. Because it is a peripheral lesion, I will go for a CT-guided biopsy. And then I will have a talk with my pathologist, and if the pathologist cannot comment on it morphologically, I will ask for just the minimum immunohistochemical markers.
Okay.
And then.
So what will be your approach? What would be your approach to get the tissue diagnosis here? Do you recommend a bronchoscopy or a transthoracic biopsy?
I will definitely, this was an HRCT thorax. I'll do a contrast enhanced CT thorax or a PET CT with contrast to look at the mediastinal nodes. So I want a mediastinal sampling also. If there is a clear-cut mediastinal node, I will go for an EBUS bronchoscopy.
You said there is no mediastinum. There are no mediastinal nodes in the CT.
Sir, in the unfortunately in the PET CT there is some parasitic nodes, but just.
So this qualifies for a question: is when will you advise EBUS or mediastinoscopy, in spite of the imaging shows absent lymph nodes or nodal stations?
So if we are going for a resection curative intent, we definitely need a mediastinal sampling.
All cases or in selected cases?
So except for peripheral disease less than 3 centimeter without a PET positivity.
So instead, you can say more than 3 centimeter lesions, more centrally placed lesions, and okay.
PET
So
positive.
and also if it is the central lesions, the PET CT sometimes misses behind the mass. There can be a mediastinal node, which is or in continuation with the mediastinal mass. Sometimes the PET CT might not detect a nodal station.
Yes, sir.
Yeah. So when will you see that still suppose you are doing a PET CT and the PET CT is showing no mediastinal node, and what is the chance of getting the node positive after the surgery?
Some
Still,
16,
there is a 20%
yes,
chance of getting the
yes.
node positive. The reason being the less than 5 millimeter may not pick up in the PET CT because PET CT has got a false positivity rate of a false negativity of 25%. So
Yes.
there can be still possibility of getting mediastinal node positive. Okay.
Yes. Yes, sir.
So can you just tell me about the nodal stages and the nodal
Yes, sir.
stations very quickly? Just
Yes, sir.
relevant things you can just.
Yes, sir. Station 1 to 14. 1 is supraclavicular node. Station 2 and 4 is paratracheal, right and left, upper and lower. Station 3 is prevascular. Station 5 is aortopulmonary window. Station 6 is para-aortic. Paraesophageal is, then we have the subcarinal is 7. Then 8 and 9 is paraesophageal and pulmonary. Then 10, 11, 12, 13, 14 is hilar, lobar, interlobar, segmental, subsegmental. So
among this, which is the one commonly missed in imaging? Station 4 and 5. Okay, because of the aortic lesions. Okay.
Yes, sir.
Subcarinal node. If suppose subcarinal node is involved, what is the station there?
Sorry, sir, I didn't hear you.
The subcarinal.
Sir, in the subcarinal nodal involvement, it becomes N2 disease. In the AJCC 9th edition, a single station N2 with a T1 is stage 2B. The rest will become stage 3.
So what do you mean by skip metastasis? Like in this connection, what is the the concept of skip metastasis, which is introduced in the 9th AJCC?
Sir, I'm not sure. Sir, is it a different?
So hilar node is N1, but without hilar node being positive, you can get a N2 node positive. So that is because of the skip metastasis, and this will qualify for the as you said the stages 2. Yeah.
Okay, sir.
So what is the final? So now what is the clinical stage? You want to again modify the clinical stage, or you want to?
Yes, sir. This is a CT2, CN2 disease. So this will become a stage 3A, 3B disease. It is multi-station versus etc. according to the PET.
So what is the difference in the 9th AJCC among this N2 nodal status?
Yes, sir. In the N2 nodal status, they have divided into N2A, N2B. This is based on single station versus a multi-station N2.
Okay. You have not mentioned about the PET CT. Anup, you want to discuss the PET CT?
No, sir. Sir, I want to ask you one thing. This patient presented with the cough only symptom.
Yes, sir.
Have you done a sputum cytology for this patient?
We did not do. He had a non-productive cough, but we did not try to get a sputum samples from him, sir.
So what is the percentage of patients getting sputum cytology in a malignant lung cancer?
I don't know, sir. I'm not sure.
What is the percentage you get with the central lesion, and what is the percentage with the peripheral lesion?
I don't know, sir.
Okay.
Okay. So what other investigation you will be asking for in this particular patient, Fatima?
Sir, at this point, I will also ask for an MRI brain.
Okay, very good. Yeah. So MRI brain is also a very mandatory investigation, and the PET CT will not pick up the brain lesions clearly. So you have to ask for a brain MRI also.
Fatima, what are the indications for MRI in lung cancer?
So,
What
except for
patients will you send for MRI brain?
in peripheral disease less than 3 centimeter without a mediastinal node involvement, I would skip an MRI and go for a resection. All other cases, I'll definitely ask for an MRI.
So you go for a MRI in early lung cancer patients? No. So if the patient is planning for a surgical intervention, will you go for an MRI?
Yes, sir. I want a proper complete staging. I'll definitely go for an MRI brain. Unless the patient has a very peripheral disease, less than 3 centimeter disease without any nodal involvement, I will skip it.
Okay.
Okay. So the PET-CT has picked up mediastinal paraaortic node. So that
Yes,
means
sir.
it is a N2 node. And so is it a single station or multi-station?
As per the PET, it is a single station disease, sir.
Okay.
It is a station 6 disease.
So will you be asking for a EBUS?
Sir, so sir, we put this case in a multidisciplinary tumor board, and we had a pulmonologist also on board, and then the pulmonologist with the image commented that an EBUS cannot pick up the station 6 node.
Okay.
And we also had a talk with our surgeon, and then he said intra-operatively he'll do a thoracoscopy and characterize the mediastinal nodes.
Okay, so you can now what is your further plan like?
Sir, ideally this patient we should be getting we'll look for limited NGS markers such as EGFR, ALK, as well as IHC for PDL1. And then if it is EGFR and ALK non-mutated, then we'll ask for
Suppose you got only very minimal tissue, then what would be your preference of choice, investigation wise? What is the order of investigation choice?
Sir, I'll ask for an EGFR, then and then ALK, IHC, PDL1.
No, you are suspecting a primary lung malignancy, and
yes.
You got only very small, tiny piece only.
Yeah.
So you want to do what is your preferred preference, the priority wise?
Yes. First of all, I'll ask the pathologist to comment on the lesion morphologically. If the morphologically clear-cut adenocarcinoma, no need for further IHC marking. But the morphology is totally differentiated.
Probably you can ask for one marker like a TTF.
Yes.
Just to confirm. Yeah.
Yes, sir.
Then
after having a histopathological diagnosis, at this point, I will also need some mutational analysis on the patient. Just EGFR, ALK, as well as PDL1.
You can ask for NGS because NGS is again doing the EGFR, yes. ALK, cross fish method, and again that will exhaust the tissue further. So probably you can ask for an NGS limited panel also, and yes. Then the last one is the PDL1. Yeah. So that's yes. That order you can do. Okay, good. So. So yeah, you can tell me the investigation reports. What is the pathology and what is the
pathology was morphologically commented as adenocarcinoma. Then we had gone for the NGS testing, which he had a KRAS G12C mutation and PDL1 TPS was 8%.
8%.
Yes, his blood parameters were biochemical profile was normal.
KRAS and
yes, sir.
Okay. Suppose this is EGFR mutation positive and
yes.
PDL1 is 80%. What would be your options?
Sir, again, this is a multidisciplinary tumor board discussion. We have data from the Neo-ADORA trial giving 9 weeks of osimertinib, but then the surgeon must feel that the disease is resectable. If that case, Neo-ADORA protocol like 9 weeks of OSI.
Okay, we will come to that later. But so right now you have a patient, 42-year-old male, non-smoker, and with a peripherally located 3 centimeter lesion. and mediastinal N2 stage. So what is the discussion? When you are discussing in the MDT, what all things you will be presenting, and what all ways you will be convincing the other team members in the MDT for your or what would be your first choice of treatment?
Yes, sir. This is a stage 3 disease. I want the surgeons to tell me whether it is a resectable disease, and the patient is fit for any modality. So if it is a non-resectable disease, the treatment differs. If it is a resectable disease, I'll definitely go for a neoadjuvant chemoimmunotherapy.
So before that, did you assess his pulmonary function? What is pulmonary reserve after the surgery? And because when you are going to present your case in the MDT, these investigations become very important.
Exactly.
Right?
Yes. So, so first of all, we have the thoracic revised cardiac risk index, and then we'll have a cardiac risk for him. And if it is a low or moderate cardiac risk, then we go ahead with the pulmonary function test and the DLCO. That is, we are looking at FEV1 and DLCO, and then we calculate the predicted post-operative value. If the predicted post-operative value is more than 60%, he's fit for surgery. If it is between 30 to 60%, we go for the level 2 test, which is the stair climb test and the shuttle walk test, 20 meter, 250 meter. If it is above that, again, he's fit for surgery. If it is below that, we need more intensive testing, such as the cardiopulmonary exercise testing.
Okay. So, what is the MDT's opinion? What was the MDT opinion in this case?
This disease was initially a T2 disease, and the nodes were very smaller. So, based on the patient preference, we had to go for an upfront surgery. So, this is the post-op HPR.
So, what is the What is the rationale for a neoadjuvant treatment, basically?
So the evidence
comes. First of all, why you didn't ask for neoadjuvant in the MDT? Because yes, especially the neoadjuvant, as a medical oncologist, you should have presented for neoadjuvant. The reason being, there is a possibility of very high possibility of being N2 multi-station in this case. So a neoadjuvant chemo or the IO and all the newer agents will definitely improve the pathological CR, right?
Yes, sir.
So that would have been the patient would have been benefited by doing the neoadjuvant treatment. So why you have not asked for the neoadjuvant treatment?
Yes, sir. No, this was like patient preference also, sir.
No, you cannot tell us that the patient preferred surgery first. Anup has asked a very important question. So now you answer Anup's question.
Okay, sir. Currently, for more than 4 centimeter up to stage 3A, there is evidence coming from the Checkmate 816 trial. And the tumor has to be non-mutated for ALK or ROS or EGFR. Chemoimmunotherapy with nivolumab has shown PCR benefit, has shown a DFS benefit, has shown a OS benefit. So we should be pushing for a neoadjuvant chemoimmunotherapy in this case.
Fatima, in simple words, which all patients will you go for neoadjuvant chemoimmunotherapy?
Resectable, stage.
So first of all, take the stage. Which sort stage will you consider?
Stage 2A to 3A.
Is it stage 2A to stage 3?
So
or stage 1B to stage 3A?
Stage 1B to 3A.
Stage 3B. Up to stage 3B, we can go for neoadjuvant. Then, any patient with a tumor size more than 4 centimeter.
Yes.
Tumor size. Then, any patient with the not positive tumors.
Yes.
Then EGFR ALK ROS should be tested and should be negative.
Yeah.
So all these patients you will go for a neoadjuvant chemoimmunotherapy. So my next question is, which all patients you will not consider neoadjuvant chemoimmunotherapy?
So the patient who will not fall under this inclusion criteria, it's EGFR, ALK, non-mutated, and if the surgeon feels this is not resectable, then the patient has any contraindications for immunotherapy.
Yeah.
The patient is not fit to
Stage
undergo.
wise, stage wise. When you talk about, you should systematically say stage first. So which all stage you will not consider for neoadjuvant treatment?
Very early stage, stage 1A, then
Yeah.
stage 3C onwards.
Stage 3 onwards. Then documented autoimmune disorders.
Yes,
You will
sir.
consider chemoimmunotherapy. Third.
Suppose the surgeon was arguing against a neoadjuvant, putting the reason as if you give neoadjuvant now it is operable, and if the patient progresses, then it becomes inoperable, and the patient is going to miss the chance of going for surgery. So how will you counter argue this for his point?
So we have evidence from the Checkmate 816 trial in
Yeah.
that.
What percentage of patients
6%.
have progressed? And less than 5%, actually. Basically, less than 5% only progressed in the Checkmate 816. And
Yes.
what is the percentage of improvement? Or if suppose you are using only chemotherapy in the Checkmate 816, what was the percentage of the PAT-CR in chemotherapy arm versus your chemo combination?
2% versus 24%.
24%. Yeah, okay, good. So that is the type of the improvement in the paths here, which we hope that the patient will get the benefit of new treatment. So what are the how many cycles of immunotherapy before surgery?
3 cycles, sir.
So 3 cycles. Okay.
So
you will be continuing nivolumab after surgery for another 1 year?
The Checkmate 816 was a purely neoadjuvant trial.
Neoadjuvant. So the later trials, they have used pre-surgery neoadjuvant as well as peri-surgery post-operative, and then continuation for 1 year. Okay. So this patient has gone for surgery, right?
Yes, sir.
Okay. So you can tell us the post-operative HPR now.
So again, HPR showed adenocarcinoma. The total tumor was 2.7 centimeter. All margins were negative. Then the patient had a visceral pleura invasion. So this was a T2 disease. Unfortunately, there was a multi-station nodal positivity. So subcarinal station 7 positivity. The station 5 AP window was positive, and station 4 was also positive.
You should have argued for a neoadjuvant, Fatima. Then now you could have told them that see the nodal state, the staging multi-stage, and 2B is the nodal state. So now the having found that N2 multi-stage, so how will you proceed further?
So now this is a stage 3B disease with a pathological N2 involvement. Based on the LACE meta-analysis, first of all, I'll give him adjuvant chemotherapy. Then, based on his NGS report, his TPS PD-L1 is more than 1%.
What do you think, Fatima? The adjuvant chemotherapy is essential. Suppose patient is telling that yeah, this has become. You said early disease initially. Now the post-operative, you are telling that it is fairly advanced. I don't want to take chemotherapy. Then how will you convince the patient about adjuvant chemotherapy?
So in the LACE meta-analysis, there is an OS benefit at 5 years of 5.4%. That will be my first argument, because
so that is an absolute improvement in the overall survival for 5 years. Okay, so that's a pretty good improvement, right? So what regimen you will offer the patient?
Sir, he's a fit patient, so cisplatin plus pemetrexed can be offered.
So what is your policy in the department? All adjuvant patients, the department prefers pemetrexed plus carboplatin or pemetrexed plus cisplatin?
Sir, if it's a young fit patient, then pemetrexed plus cisplatin. And then
is there any difference between cisplatin and carboplatin? Just like in the testicular tumor, where we know that cisplatin scores over carboplatin. So here, is there any difference actually?
No, sir. I think no, sir.
No, Fatima, it is very, very important. Cisplatin scores over carboplatin in the adjuvant setting.
Oh, okay, sir.
And the vinorelbine plus cisplatin 4 cycles will be the standard of care. And carboplatin is only in the palliative setting, or when patient has either CKD or with the GFR less than 60%, or the patient cannot tolerate cisplatin because of the cardiac issues. Otherwise, cisplatin is the trigger, the adjuvant drug of choice. Okay.
Yes.
So,
Fatima, what is the dose of cisplatin in lung cancer?
So 75 milligram per meter square every 21 days for 4 cycles.
What about pemetrexed?
500 milligram per meter square, again, every 21 days for 4 cycles.
How it is given, pemetrexed?
Sorry, sir?
How it is given, pemetrexed?
Pemetrexed, 1 week prior to starting, folic acid 400 to 1000 microgram per orally, vitamin B12 1000 microgram per orally. The creatinine clearance should be more than 45. Then dexamethasone 4 mg BD on 1 day prior, the day of, and the day after. And pemetrexed should be given prior to cisplatin. We diluted it in 100 ml NS, and it is given over 10 minutes.
But here you give folic acid for pemetrexed.
Pemetrexed is a targeted folate receptor antagonist. So to combat the neurological as well as the myelosuppressive effects, we give folic acid as well as vitamin B12.
So here it is N2 disease. So you want to, do you think there is a role for radiation in this case? The MDT radiation oncologist is arguing for postoperative radiation. So what do you think, this patient is going to be benefited by offering radiation or not?
The evidence is controversial. There is definitely evidence for positive margins. We give post-operative.
Tell about the LungArt trial. LungArt trial is the landmark trial which has shown some light on the post-operative RT.
So in the LungArt trial, they showed that there was a local regional benefit. Recurrence is benefited, but there's no overall survival benefit.
Overall survival. So post-operative RT is probably we might give in N2 multi-station, and also a positive margin, and as well as some extracapsular extension of the nodal sheet. So this is what LungArt trial is telling us. So suppose this patient EGFR is positive, then what would be your adjuvant choice?
I will start off with the adjuvant chemotherapy, followed by osimertinib for 3 years.
Why chemotherapy? Because osimertinib, the EGFR is positive. Then why do you want to give chemotherapy first, and then why do you want to postpone osimertinib till the adjuvant chemo?
We have always benefit from adjuvant chemotherapy, so we do not miss it. Suppose the patient has some OSI-induced adverse effects.
No, Fatima, ADAURA trial, the trial clearly showed that the ADAURA trial tested like the chemotherapy, 4 cycles of chemotherapy followed by osimertinib. So the standard practice has become the 4 cycles of chemotherapy followed by osimertinib. And one more reason for the reason being, TKIs are basically cytostatic, so they will not cure the disease. So so that is why we want to use chemotherapy first, and then reserve TKI for after the chemotherapy.
Yes.
So Fatima, you are given chemotherapy for these patients. So what are the indications for adjuvant chemotherapy in lung cancer?
Any tumor size more than 4 centimeters, node positivity.
Stage wise?
Stage wise. So
you can say T1A, T1B, T1C, like that.
Say stage 1B onwards.
Stage 1B to stage 3B.
Yes, sir.
Okay, so suppose you have a stage 1A with higher risk features. What is higher risk features?
So in that place meta-analysis, 1A did not show benefit with adjuvant chemotherapy. So we can just follow up that patient.
So some patient has got a high-risk features. So can you define high-risk features?
So poorly differentiated, positive margins, LVSI, extranodal extension.
Yeah, then it will not become T1A, you know.
Yes.
So patient with the poorly differentiated carcinoma, patient with the vascular invasion, patient with the unknown lymph node status, and patient underwent wedge resection. So all these patients will go for a chemotherapy, adjuvant chemotherapy.
Yes.
Fatima, if this patient ALK is positive, then what would be your adjuvant choice?
In the ELINA trial, they did not give the adjuvant chemotherapy. Without the adjuvant chemotherapy, we can give alectinib for a total of 2 years.
So after chemotherapy, you will give alectinib, right?
Or we can do away with the chemotherapy also. In the ELINA trial, they did not give.
What is the landmark trial where alectinib become standard of care for in the ALK positive adjuvant setting?
So ELINA trial.
ELINA trial. So ELINA trial, what is the two subsets or the two arms? Can you tell me the two arms for the ELINA?
Oh, I'm not.
Chemotherapy versus the alectinib only. And there is no chemotherapy versus chemotherapy plus alectinib. So that is the reason why alectinib is prescribed adjuvant, where chemotherapy is not routinely administered. And also there are studies which have shown that exposing anti-ALK is early is better than postponing it after the chemotherapy. So the chat box, I just saw the question of why osimertinib is given is not given upfront. It's given after the chemotherapy. The ADORA trial, which has shown that which is actually the tested chemotherapy versus chemotherapy plus followed by osimertinib. That is one reason. Second reason is osimertinib is in lung cancer. It is cytostatic. It is not a curative thing. So we invariably, because being an early disease, we want to give the benefit of chemotherapy in the adjuvant setting, and the TKI will be given after the adjuvant chemo. That's how it is planned.
Fatima, suppose.
Yes, sir.
Fatima, suppose this patient has got a stage 1A disease post surgery, and ALK is positive.
Yes. So again, I will just follow him up, sir.
Okay, very good.
So now the question comes. The first question I asked you about the PD-L1 is 80%.
Yes, sir. And EGFR is positive.
And EGFR is positive, right?
Yes.
So what will you do?
So definitely go for the ADORA protocol, sir.
ADORA trial, because So what is the reason why you don't want to give immunotherapy in this case, because it is 80% positive?
Yes, an EGFR mutated environment is immune cold, so not much of an immune cells is there, so immune reactivity is lesser.
And also there are problems like the ILD, incidence of ILD is high if you use immunotherapy or combined immunotherapy. So that is one of the reasons. So the PD-L1 positive, suppose a patient is mutation wild and patient is PD-L1 positive, then what would be your approach?
Sir, in the adjuvant immunotherapy settings, we have data for pembrolizumab, we have data for atezolizumab. For atezolizumab, we need a TPS more than or equal to 1%. And for pembrolizumab, it is independent of PD-L1. Both has shown DFS benefits.
So what is the benefit? Can you tell me what is the hazard ratio and the overall survival? What is the difference?
So the overall survival data is not mature. In the pembrolizumab, there is more than 50%. There is no statistically significant benefit in DFS. But for atezolizumab, TPS more than or equal 50%, there is a statistically significant benefit in DFS, which is with a hazard ratio of 0.4. I'm not sure.
0.4, yeah. Okay. So, so Anup, anything else you want to ask other than this?
So
basically, we have not touched upon the toxicity part, Anup.
yeah. Okay. So what are the autoimmune toxicities when you come up when you administer or immunotherapeutic agents, Fatima?
The IRA, as per the time of onset, the first is probably skin rashes that occurs at 4 to 6 weeks. Then comes the colitis, nearly 6 weeks. Then we have more beyond 6 weeks, we have ILD. Then we have hepatitis. We have adenohypophysitis. And of course, early onset, we have endocrinopathy such as hypoadrenalism, hypothyroidism, etc. And then late onset, we have myocarditis, nephritis, etc.
So which all autoimmune toxicities you will consider continuing treatment with the symptomatic treatment of toxicities?
Skin toxicity, endocrine toxicity, as well as colitis.
Okay. Will you continue steroids in that case along with the treatment, or you'll just hold?
So if at all I can hold steroids, I will consider that. But then even very low dose steroids can be considered.
Okay, you still use steroids along with the chemotherapeutic agents when you give chemoimmunotherapy, or you will not give steroids?
Sir, the very high dose steroids will definitely be avoided. Of course, in the patient has an adrenal suppression, we have to give them maintenance dose of hydrocortisone. So in this case, when we are giving along with pemetrexed, we give the low dose of dexamethasone as well as the antiemetic dose of dexamethasone.
Okay.
Where we can avoid, we avoid, sir.
Okay. So if you're considering consolidation immunotherapy,
yes, sir.
So which agent is used for consolidation immunotherapy after CTRT?
After CTRT, we have data from the Pacific trial to use durvalumab. After 6 weeks of CTRT, if there is no progression and if there is no grade 2 or more radiation-induced pneumonitis for up to 1 year.
Up to 1 year. Suppose if it is EGFR positive?
We have data from the LAURA trial to use osimertinib maintenance indefinitely or until disease progression.
Why it is indefinitely? Why
because
it is not 3 years? Because in the ADAURA trial, you have given for 3 years only. But in stage 3, with the consolidation immunotherapy, you advise.
So if we are giving CTRT, the patient is probably CC, and it is considered to be a systemic disease rather than a localized disease, considered to be an advanced disease. So it has a high propensity to come back.
Is it the reason?
I'm not sure, sir.
Yes, that is because in ADAURA trial, after stopping 3 years of osimertinib, patient started getting relapses. Okay, so that's the reason why they put it as indefinitely in patient consolidation, anti-EGFRI. So after 3 years, up to 3 years, if you're continuing osimertinib, patient is somewhat safe. But when you suddenly stop for 3 years, suddenly the patient will relapse. So that's why you can, in the next years, they modify the treatment up to indefinitely. Okay.
Okay.
So basically, what is coming to the ADAURA trial? What is the maximum benefit we have seen? What is the advantage of using adjuvant osimertinib actually?
So there's definite PFS benefit. The median PFS was nearly 3 years. OS data is still not mature, but
actual benefit is because it delays the brain metastasis. That is the reason why people want to. The maximum benefit is shown in the ADAURA is that. Okay.
Yes, sir.
Okay, so
what are the toxicities when you give osimertinib?
Because
Long
it's
duration.
because of the EGFR mutation, we are expecting skin rashes, acneiform rashes, paronychia, then mucositis, diarrhea, also cardiac toxicity such as QTC prolongation, cardiomyopathy.
Okay. So in the chat box, I've seen one. I just now I saw one more question asking about whether the lorlatinib can be replaced, can be used to replace alectinib. Instead of alectinib, can we use lorlatinib in the adjuvant setting? I think the studies are going on. The data is not yet mature. So at the moment, the recommendations are only for the alectinib, because the first study published is Alina trial. So I think Anup, we have in the last 1 hour, I think we have discussed almost touched upon all the points. And if anybody has any doubts, probably you can put it in the chat box, and we will try to answer. Fatima, you have done very well, and actually you have answered almost all questions, and your performance is above average, and the both of us are very happy about the way you have answered the question. It's very important for the when you get a lung cancer, it's a long case for your exam, and there are different types of examiners. Basically, some people will be asking more about the history and the physical examination points. So be prepared for all, and some will be concentrating more on the treatment part and the management part, especially all this important treatment decisions and algorithms. You have to be very thorough. You have to be thorough, and what are the patients fit into various different the different types of clinical settings. So that is very important. So Anup, you can conclude.
Yeah, thank you, sir. Yeah, Fatima, you did well. You answered most of the questions,
Thank you,
and
sir.
it's good. Sir, anything to add?
I think Anup sir has left the meeting. Thank you so much, sir. Thank you so much, Dr. Anup, sir, and Warrior, sir, for this excellent opportunity for us to learn, actually. And I would also like to congratulate Dr. Fatima, because she agreed at the last moment to present this time. So thank you so much for the cooperation, and I think we'll call it a good night, and we'll meet again next month for the next presentation. Thank you so much.
Thank you.
Thank
Yeah.
you.
Thank you all.